This is my first video on this YouTube channel, and on this YouTube channel I'll be uploading a series of videos on the basics of cardiology, and where I'll be simplifying the concepts of cardiology in a very basic manner or in a very simplified way. And today I'm starting with the topic aortic stenosis, and I'll be simplifying its concepts as much as possible. So let's start. So what do I mean by aortic stenosis? Aortic stenosis just means a narrowing of the aortic valve. So the aortic valve is narrowed, which leads to an obstruction to the blood flow from the left ventricle to the ascending aorta during the systolic phase. So during the systolic phase, when the heart contracts or when the ventricle contracts, the blood flows from the ventricle to the ascending aorta. But due to a narrowed valve and due to a calcified valve, there is an obstruction to the flow from the ventricle to the ascending aorta, and this obstruction is known as aortic stenosis. So on the upper right hand, we can see there is a calcified fibrous stenotic valve. This is the aortic valve, it is tricuspid, right? And there's a restricted opening of the valve, so we can see in this image, and due to this restricted opening, the blood cannot flow easily from the ventricle to the aorta, right? The normal aortic valve area is 3 to 4 centimeters square. You can see this is a normal surface area of the valve, and as the stenosis progresses, the surface area decreases, right? And when there is significant stenosis, the surface area is about less than 1 centimeter square. So less than 1 centimeter square area of the valve means there is severe stenosis. Below we can see an analogy of the pipe. So here the stenosis, so there is an stenosis, there is an obstruction to the outflow, and as the obstruction progresses, there is immense pressure on the lower side of the pipe, right? So we can correlate this immense pressure to the immense pressure that the ventricle, so there's the ventricle is under an enormous pressure because of the stenotic valve, as it cannot transfer the blood from the ventricle to the aorta, right? So here this is the normal healthy aortic valve in its open state. That means the systolic phase of the heart, and here it is in the closed state, that is known as the diastolic phase of the heart. In the diastolic phase and the closed phase, the valve looks like that of a logo of the Mercedes Benz, right? Now when there is aortic stenosis, the opening, that is in the systolic phase, the opening is very narrowed and the blood cannot flow from the ventricle into the aorta. And during closed state there is no problem because the valve is closed, right? But when it is open, it does not open fully, causing obstruction to the flow of the blood. Now aortic stenosis is one of the most important cause of left ventricular outflow tract obstruction, which is known as LVOTO. So left ventricular outflow tract obstruction has lots of causes, like there could be supravalvular obstruction, that is a congenital supravalvular ridge, right? We can see in the image there is a supravalvular ridge which is congenital, which is causing obstruction to the outflow, right? And there could be a subvalvular obstruction, so below the aortic valve there could be a subvalvular ridge, congenital ridge, causing an obstruction. And also the most common cause is aortic stenosis itself, and there could be an intraventricular obstruction. Now the most common cause of intraventricular obstruction is hypertrophic obstructive cardiomyopathy, also known as HOOCM. In this case, there is hypertrophy of the myocardium of the ventricle, and this hypertrophy leads to decrease or obstruction to the outflow of the blood from the ventricle into the ascending aorta. So these are the causes of left ventricular outflow tract obstruction. Now the supravalvular obstruction is associated with a syndrome which is known as Williams syndrome. In Williams syndrome, so there is supravalvular aortic stenosis, right? The child has supravalvular aortic stenosis, and the face is very diagnostic. That is, the child has elf-like appearance. The head is very small, right? We can see in the image. There is a low nasal bridge. Eyes are very puffy. Cheeks are full and baggy, and the mouth is very wide with a very widely spaced teeth, right? And the chin is very small. So you can see in the image all the characters, the face, all the facial features in Williams syndrome, which is very diagnostic. And the child also has mental retardation with hypocalcemia. So all of these features, which includes supravalvular aortic stenosis, a very diagnostic phase, mental retardation, and hypocalcemia, which is the features of Williams syndrome. Now, the Williams syndrome is basically there's a defect in the chromosome number 7, in which there is deletion of about 27 genes, which causes this syndrome, right? Now, so let's talk about the causes of aortic stenosis. What are the different causes of aortic stenosis? The most common cause of aortic stenosis in adults is a degenerative calcification of an congenitally bicuspid aortic valve. Now, what do I mean by bicuspid aortic valve is that the aortic valve is usually tricuspid, that is, there are 3 cups, 1, 2, and 3. But in a child with a congenitally bicuspid valve, that means the aortic valve has only 2 cups, and it is not as efficient as that of a tricuspid aortic valve. And in that case, eventually, there is more stress on the valve. So there is more stress on the aortic valve, and this stress will eventually lead to degeneration. So it eventually will lead to degeneration and calcification. So calcification of the valve, right? And the other causes that is most common in adults is a rheumatic inflammation or rheumatic heart disease. Rheumatic heart disease affects the mitral valve first, and his second favorite site would be the aortic valve, right? So in rheumatic heart disease and in with a child with a congenital bicuspid aortic valve, that would be the most common cause in adults. Now, why I'm saying adults? Because a child with a congenital bicuspid aortic valve will not present as a child, because it takes a lot of time to develop the symptoms. So the age of presentation is very delayed. So a child who was born with a congenital bicuspid aortic valve will present at his midlife, about 30s or 40s, with symptoms. So he will be symptomatic in his midlife, right? So that's why I'm saying AS, the most common cause in adults would be a congenital bicuspid aortic valve which undergoes degeneration, and a previous rheumatic inflammation in which the mitral valve is affected first and then the aortic valve second. In older people also, the normal aortic valves, normal structure of the aortic valve may be fibrosed or calcified, which cause stenosis. So it takes a lot of time to develop a hemodynamically significant stenosis. In case of bicuspid aortic valve, a hemodynamically significant stenosis is only developed after 50 to 60 years. So when the patient is 50 to 60 years old, then only he will develop symptoms, right? And in case of senile degeneration or in old age, the age of presentation is even delayed. It is about 70 to 90 years. So in 70 to 90 years old, only the patient will present with symptoms in case of senile degeneration, right? So other causes include radiation as well. So here congenital is the most common cause, right? Bicuspid or unicuspid, degenerative calcification, rheumatic heart disease, and radiation at last, right? Now here I'm showing the pathogenesis of calcification of the aortic valve. Now, how does calcification really occurs? How does fibrosis really occurs, which lead to stenosis of the valve? So initially, let's take an example of bicuspid aortic valve. So initially, the bicuspid aortic valve is not as efficient, right, as a tricuspid aortic valve, and it undergoes a lot of mechanical stress, right? And this is the valvular area. So this is the endothelium of the valve, and due to mechanical stress, there is endothelial damage, right? There is endothelial damage, and as there is damage, there is inflammation. So there is intense inflammatory infiltrates, right? Monocytes, macrophages, T cells, intense inflammatory infiltrates into the valve, and also the patients which are at risk, right? The risk factors includes dyslipidemia, hyperglycemia. So basically, diabetes, people with diabetes or hypercholesterol, hypercholesterol, increased cholesterol, dyslipidemia. So there are basically those people are at risk. So we can say this process is same as that of atherosclerosis, right? So the people who are at risk has increased low density lipoproteins, right? And increased inflammation will cause increased entry of low density lipoprotein into the valve, and eventually this inflammatory infiltrates will release free radicals. They will release free radicals, and these free radicals will eventually oxidize the low density lipoprotein into its oxidized form. So it would make the low density lipoprotein into an oxidized low density lipoprotein, and the oxidized low density lipoprotein is very capable of intense inflammation. So it is very capable of stimulating an intense inflammatory reaction. So the low density lipoprotein oxidized form will cause even more inflammation, and eventually there will be release of pro-inflammatory cytokines. So these are pro-inflammatory cytokines, TGF, beta, TNF alpha. So these are pro-inflammatory cytokines which basically drives the conversion of a fibroblast into a myofibroblast, right? And then the myofibroblast will cause intense fibrosis of the valve. Right? This intense fibrosis of the valve will eventually lead to thickening and stiffening of the valve. And after many years, the myofibroblast will get differentiated into an osteoblast by a procalcific pathway. So OPZ, rank L are responsible for this conversion of a myofibroblast into an osteoblast, and this osteoblast will eventually cause increased calcification and bone formation. So this process is same as that of a lamellar bone formation, and eventually there will be calcification of the valve. So let's just summarize. So initially there is inflammation, right? So initially there is going to be inflammation. This inflammation will eventually lead to fibrosis, and at last there will be calcification of the valve, right? This is all we talked about, right? So next, so those the normal leaflets could be either bicuspid or tricuspid, and both of them are at risk. Now what are the risk factors, right? So risk factors, as I already told you, the risk factors of atherosclerosis, right? Like the risk phenotype, right? Risk valve morphology as that of a bicuspid aortic valve, dyslipidemia, diabetes, hypertension, smoking. So these are all the risk factors of atherosclerosis which are present in a patient with aortic stenosis, and these risk factors will eventually lead to aortic sclerosis. Now what do I mean by sclerosis, and what is the difference between sclerosis and stenosis? Now sclerosis means just thickening of the valve, so there is only thickening of the valve and fibrosis of the valve. But stenosis means there is calcification and progressive obstruction of the valve. So obstruction, before obstruction it is sclerosis, and after the obstruction it is known as stenosis. Now as the sclerosis progresses, about 10 to 15% of the patient will eventually develop aortic stenosis, right? And we can look down here. The initially the graph is very linear, right? But as calcification develops the valve, there's an exponential rise in the progression of the disease. So you can say as calcification develops, there's an exponential rise in the progression of the disease, and that will eventually lead to the patient being symptomatic, right? Now let's just discuss about the pathophysiology that is associated with aortic stenosis, or how this aortic stenosis eventually is going to cause it's going to cause left ventricular failure, or eventually causes symptoms, right? So there's a stenosis. Initially there's going to be a stenosis in the valve, right? And this stenosis will basically cause increase in pressure in the ventricle. So ventricular pressure is very high because ventricle cannot transfer the pressure that is generated within the ventricle into the aorta. That means the ventricular pressure is very high and the aortic pressure is quite low, right? This increased ventricular pressure I'll draw here. So this is the atrium, this is the ventricle, and this is the aorta, right? So here this is a stenotic valve, right? So this is a stenotic valve, and here this is the mitral valve, right? So as there's a stenosis, the pressure in the ventricle is going to rise and the pressure in the aorta is going to be quite low, and this increased ventricular pressure will eventually lead to increase in wall stress. So that will lead to increase in wall stress, that is the left ventricular wall is at a very immense stress. So initially due to increased stress, the ventricle has to overcome this stress in order to pump the blood from the ventricle into the aorta. So initially it cannot do that, so there will be decrease in stroke volume, right? Stroke volume means the amount of blood that is transferred from the ventricle into the aorta per beat. So per cardiac cycle, how much amount of blood is transmitted. So as there is stenosis, the amount of blood transmitted is quite low, so there is decrease in stroke volume, which will eventually cause increase in the end systolic volume. That means if low volume is getting transferred from ventricle into the aorta, that means at the end of systole there will be increased volume, in the ventricle. And after the systolic phase there will be diastolic phase, where there will be filling from the atrium, right, and that will eventually lead to increase in end diastolic volume, right. So eventually there will be increase in the end diastolic volume. Now increase in diastolic volumes means increase preload. So increase volume means increase end diastolic volume means increase preload in the heart. So preload means end diastolic volume. So increase preload. So increase preload means the myocytes are basically stretched very apart. Because of increased volume, the myocytes are very stretched apart, and that will cause increased calcium entry into the myocyte, and that will increase the force of contraction. So force of contraction of the ventricle, so force of contraction is increased. What is this law known as? So this law, that when the preload is increased, that causes increased force of contraction, is known as Frank-Starling mechanism. So we all have studied this Frank-Starling mechanism in our MBBS years. So increased preload will eventually cause increased force of contraction, and that law is known as Frank-Starling mechanism. And this is just a compensation, right? So initially there will be increased force of contraction, and that is just a compensation, right? So compensation to decrease stroke volume. Now this force of contraction, now the stenosis, as the stenosis progresses, right, so this force of contraction is also not enough to maintain the stroke volume, and the ventricle has to find other alternative, and that will be it will undergo hypertrophy. So it will undergo hypertrophy. So due to increased pressure load, this will eventually undergo hypertrophy. So there will be hypertrophy of the ventricle, and a hypertrophic ventricle is not as compliant as a normal ventricle. So what I mean by compliant means a compliance is anything, right? Anything that is compliant can store a large volume in it, and it can expand, right? So as the ventricle undergoes hypertrophy, right? So hypertrophy, it cannot expand anymore, right? So decreased expansion means decreased compliance. So it is less compliant. That means the atrium had to generate more pressure in order to fill this less compliant ventricle. Initially the atrium cannot do that, right? So that means the blood will start to back up into the atrium, and from there the blood will start to back up, or pressure will increase in the pulmonary arteries, and eventually in the pulmonary capillaries, right, the pressure will increase. This increased pressure will eventually lead to pulmonary edema, right? So increased pressure here, this is the pulmonary capillaries, right? So increased pressure in the pulmonary capillaries will eventually lead to blood to start to back up into the lungs, right? So that will lead to pulmonary congestion, and due to this there will be decrease in gases exchange in the lungs, and that will eventually lead to symptoms like dyspnea. The patient will have symptoms like dyspnea because of pulmonary congestion, right? And eventually the atrium will start to counteract. So eventually the atrium will start to counteract this increased pressure. How would atrium counteract? Is basically the atrium will undergo hypertrophy itself, right? The atrium will undergo hypertrophy itself, and as the atrium has undergo hypertrophy, the pressure start to normalize in the ventricle as well. But still, if the stenosis progresses, and it will progress if it is not treated, an increased progression will eventually lead to increased stress, and that will eventually lead to contractile dysfunction. So now the ventricle cannot contract anymore. That will lead to contractile dysfunction, and that will eventually lead to congestive heart failure. So left ventricular will eventually fail at its job of pumping the blood, and that will eventually increase the pressure in the atrium and pulmonary arteries, and lots of symptoms that we can see, right? Now what are the symptoms? So what are the symptoms that this congestive heart failure or left ventricular failure will eventually lead to? That is, the first, there's a triad of symptoms in aortic stenosis, which is known as, initially there is angina, and there is dyspnea and syncope. Now these all symptoms will basically be experienced during exertion. So at rest the cardiac output, or at rest the cardiac output is maintained, but during exertion or during exercise the cardiac output has to be high in order to maintain, right? During exercise the cardiac output has to be high, but heart cannot maintain the high cardiac output because it already has undergone hypertrophy, so it cannot maintain the high cardiac output needed during exercise, and that will cause angina because there will be decreased perfusion of the coronary artery. So there will be decreased perfusion of the heart, so there will be decreased perfusions via the coronary arteries. So there is decreased perfusion because the stroke volume is decreased, because the cardiac output is decreased. That will lead to eventually ischemia of the myocardium, because the myocardium is hypertrophic, that is the demand is very high. So myocardium has a high demand, and the supply is very low because the heart cannot pump blood efficiently. That means increased demand, decreased supply will eventually lead to ischemia and cause angina, right? Next symptoms would be dyspnea, which I already explained how, right? And syncope. Now during exercise the arteries in the muscles are heavily dilated because they require more blood. That means more blood flow to the muscles. That means, so this is the muscles, so more blood flow to the muscles means less blood flow to the brain, and that means the brain will go on into hypoxia, and this hypoxic state will eventually lead to syncope. So syncope means just transitional loss of consciousness. The patient will have transitional loss of consciousness during exercise, and the patient, if there is very less supply to the heart myocardium itself, the patient may eventually die because during exercise there is intense vasodilation of the muscles and the blood flow to the myocardium is very less, so heart has very less blood supply to itself, right? And that could eventually lead to a death to a person. So a patient or may come, right, that during exercise, so during playing a game he suddenly collapsed and he died. Why? Because during exercise the blood flow to the muscles were very high and his myocardium did not get the blood supply, and this could be caused due to aortic stenosis, right? So this is how the heart will eventually undergo left ventricular contractile dysfunction because of aortic stenosis, and all the symptoms starts to generate. Now here I'm trying to explain, this is the normal cardiac cycle, right? So in normal cardiac cycle we can see that this is the atrial pressure in yellow, right? And the green there is the ventricular pressure, and in red this is the aortic pressure. Now in a normal cardiac cycle, as the ventricular pressure rises, and when the ventricular pressure is greater than the aortic pressure, the aortic valve opens and the aortic pressure is going to go along with the ventricular pressure. But in case of aortic stenosis, what happens is as the ventricular pressure rises, the aortic pressure cannot rise as much as the ventricular pressure because the pressure is not transmitted into the atrium because of the stenosis. That means the ventricle will have a very high pressure, right? Here we can see very high pressure, and the aorta will have very low systolic pressure because the pressure cannot be transmitted from the ventricle into the aorta. That means there's a very big gap between the pressure, systolic pressure of the aorta and the ventricle, and this is known as a pressure gradient. So this difference is known as pressure gradient. In a normal cardiac cycle there is no pressure gradient, but in a stenotic heart there is a systolic pressure gradient. So this process is during systole, so it's known as systolic pressure gradient, or there is a pressure gradient. That means there is a difference in pressure in the aorta and the left ventricle during systole. So we can see that in this image on the right side, that in a normal heart the systolic pressure is 120, and at the same time the systolic pressure of the aorta is 120 because same amount of pressure is transmitted from the ventricle into aorta. But in a stenotic valve, what happens is that the pressure is going to rise in the ventricle, but the pressure in the aorta is very low because same amount of pressure cannot be transmitted from the ventricle into the aorta in a stenotic valve. So that leads to a difference in pressure into the ventricle and the aorta, right? And that difference is known as a pressure gradient. Now why am I focusing on a pressure gradient so much is that this pressure gradient will basically determine the severity of the aortic stenosis. How severe aortic stenosis is basically defined by the pressure gradient, right? So more pressure gradient means more severe the disease, right? So for today this is all I have for you, right? In the next video I will explain about the clinical features and how do you diagnose a patient with aortic stenosis. in the upcoming videos. If you liked my content, please feel free to like and subscribe my channel, and if you have any queries or any feedback, feel free to comment down below.